Mohsin sir, just after 10 seconds you can start to you talk. স্যার শুরু করেন।
Good evening. Assalamu alaikum. Welcome you all. Today's Cathlab manual series, especially today's CTO manual series. It is part 1, and on 11th March is part 2. We are very much grateful to Dr. Arun Kalyanasundaram. He is with us. Just little introduction for him. He is an eminent interventional cardiologist, associated with many leading hospitals globally. He is the Chief Division of Cardiology, Promed Hospital, Chennai, a global proctor. This internationally authorized to teach complex cardiac intervention to other medical practitioners for CTO, also different medical technologist, and he also director of Fortis Scott Hospital, New Delhi, India. Also, he's the very much popular in Bangladesh. Welcome, Dr. Arun Kalyanasundaram, to be here. He will meet again on 11th March, Thursday at same time. Also, another speaker here, Professor Saidur Rahman. He also expert cardiologist in Bangladesh, also eminent cardiologist, is doing very well in CTO. Welcome, Dr. Professor Saidur Rahman. Here, Professor Arun Maski from Nepal also. I welcome another our eminent cardiologist, Professor Abdul Jamil, Dr. Khanduk Asadujaman, Masud Jiyachudi, lots of panelists here. So let's start our talk. After 30 minutes discussion, we'll talks again, different discussion, another 15 minutes. Thank you, everybody. I welcome Dr. Arun Kalyanasundaram. Please continue your session. Dr. Arun Kalyanasundaram.
Great. So I would really like to thank the organizers for having given me the opportunity to present today. I think it's a great thing that you guys are doing, and it's truly an honor and a privilege. So I will, without much ado, get going. Let me see how to do this. Basic. Okay. Every time. Show all windows. Okay. There we go. Okay. I think you guys can see my screen now. So today we're going to kind of go over the basics, really. So I understand the target audience is primarily early to mid-career cardiologists and some fellows. So I'll try to kind of stick to the basics here. So we're going to talk today about when and why we do CTOs. What are some of the basics? What are some of the things that you look for or look forward to when you do a good angiogram? What are some of the predictive scores, and also kind of touch on toolkit. You find a lot of reasons to not do stuff, right? It's already bypassed, it's already done. You know, complication rates are too high, it's collateralized, whatnot. But fundamentally, on good medical therapy, you know, if patients have symptoms, so relief of angina / ischemia, I think is a lofty goal, and that's okay. That's number one. Number two is sometimes when you have impaired LV function and good viability, many times I think Cto Pci is indicated. You know, potentially reduced incidence of late CABG and possibly improvement of event-free survival. I would say these two are debatable, but 1 and 2 I think are pretty much, we could be rest assured that these are good indications. And now, many times in our parts of the world, and I'm assuming Bangladesh is not very different than India in this aspect, we are like, all right, that's a CTO, so I'm going to send the patient for bypass. Now, especially if you're not going to put in a lima, and now we're not talking about a proximal LAD CTO, etc. We're talking about, let's say, a CIRC or a RCA. When we talk about, you know, surgical revascularization, you know, typically the advantage of long-term patency is just gone when you compare PCI versus bypass surgery when we are doing a vein graft. So this data actually from the UK, a hybrid CTO registry, better syntax, and only about 2/3. Many times we send them for bypass surgery, saying, all right, it's a CTO, go ahead and bypass it. And oftentimes, even in good surgical hands, we keep hearing, well, it's too small to bypass. In good centers, mostly our success rates are well north of 90%. This is from UK Hybrid Registry, and when you look at long-term patency, it's pretty darn good. Data from Prague actually would tell you that when you send them for a vein graft, 1-year patency is really dismal. So you're looking at potentially, I mean, this is obviously data from multiple registries, but you're looking at less than 20% of vein grafts from when we referred them to patency at 1 year, compared to about 80% on the other side. Now, fundamentally for the fellows, I guess there are 4 ways of crossing a CTO. You can either go antegrade true-to-true wire escalation, right? You can go retrograde true-to-true wire escalation. Here we are staying intraplaque all the way through. Or you could go antegrade dissection reentry, where you get into the adventitia and re-enter, or you could go retrograde dissection reentry. So long and short of it is you got to connect points A and B. So again, another pictorial representation. Wire escalation is along the direction. Antegrade wire escalation is along the direction of blood flow, where you try and stay intraplaque. Dissection reentry is where you get into vessel architecture, re-enter. Retrograde wire escalation is opposite direction, but you're still staying intraplaque. Reverse card or retrograde dissection reentry is where, once again, you're in the vessel wall, but you go primarily retrograde, and there are various permutations and combinations thereof. So before we get into the brass tacks, couple of things. You have, when we talk about proximal cap, we're talking about that part of the vessel at which the CTO segment starts. Lesion length refers to the length of the CTO segment. Distal cap is where it's the distal cap of the CTO. So from where you can see the vessel again. And then of course you have the other term often that you hear is collateral channel, meaning how, I mean, this vessel is somehow getting blood. Oftentimes it's through collaterals. So when you talk about collateral channel selection, that's what we're referring to. And what is donor vessel? Where is the dominant collaterals from? That is typically referred to as the donor vessel. So all this can be put together, and I'll kind of go over this in a little bit to kind of have a plan. Like you want to go in, not I'm like, oh, I see a CTO, I'm just going to go and poke, right? So we use a couple of anatomical factors to decide how we go about treating or approaching the CTO. So, and I'm going to, so I just put this up, but I'll go over each step in a little bit. So it is critically important that we really evaluate the angiogram in great detail. And I'll kind of show you what is a good angiogram. So if you want to study CTOs, and this really helps, kind of optimize your chances of success. So when you do an angiogram, you want to do it on low mag typically. If you can, do it bilateral as shown here, but not everyone always does, but that's all right. As you can see, there's no panning. You want to have a long run so that you can wait to see how the collaterals fill. Perhaps if your machine can go into a higher, I mean, typically we do the 7.5, 15 frames. This is the one time when you're actually doing your setup shots, you might want to consider a higher frame rate. And after you do all this, spend time, look at the collaterals, see what what can be done, how's the proximal cap, etc., etc. So now, let me go over each aspect. So typically, you want to first look at the proximal cap. Is it first of all ambiguous or discrete? Once you know that it is unambiguous or discrete, you want to look for, is it tapered, meaning is it like this, or is it blunt, where that's the opposite of a tapered. It's just a flat area that you got to penetrate. And the big question is, do you even know where it is? Because if you don't know where it is, it's ambiguous. So I'm going to kind of skip that part. So different people might have different definitions for what is ambiguous or not. So what might be ambiguous to me might not be ambiguous to another CTO operator and vice versa. But in general, if you're confident of taking a penetrative wire and a microcatheter and sticking it in, that's unambiguous. If you're not sure, that's ambiguous. So many times IVUS can be utilized to resolve proximal cap ambiguity. So one of the other solutions is to go retrograde. I'll touch upon that shortly. There's another term that we refer to as the landing zone. Now, I already told you what the distal cap is. That part of the vessel beyond the distal cap is what we refer to as a landing zone. So sometimes you'll hear this. Is it a good landing zone? Is it not a good landing zone? And the various things that make it. Is it like disease-free? Is it calcific? Blah, blah, blah. Again, a smallish vessel might be a poor landing zone, especially if you have a lot of significant branches. A good landing zone is devoid of branches and it's pretty juicy. It's a good sized vessel. Now, collateral filling again. This is a slam dunk. I mean, you got a million collaterals to choose from. This is not bad. I mean, in fact, they said it's non-interventional, but it's definitely a high grade interventional collateral, if you're going to call it that. So how do we put this together, right? And before we go into the last part, lesion length, or as is referred to in the APCTO, the long plus, really is just a determinant of, do you think you can wire this or do you think you can't? If you think you can wire it, then it's we often use wire-based strategies. If you think you're not going to be able to wire it due to a plethora of reasons, then you might want to consider dissection as a primary strategy. So when we say dissection, what do we mean? It can be antegrade or retrograde. Antegrade dissection oftentimes is a knuckle wire or a cross pass. Retrograde dissection is always a knuckle wire. And then how do you re-enter? You re-enter typically, if you have a Stingray balloon catheter, it's a controlled re-entry. Now, there are other ways to re-enter. You could just star in, like, knuckle push it really hard and you'll get in mini star, contrast, last, which is really penetrate a wire and trying to re-enter. And typically the only way you re-enter when you go retrograde is reverse cut for all practical purposes. Again, there are exceptions. Why do we actually even care about dissection re-entry? A penetrative wire could easily exit the vessel architecture when you have an ambiguous course, when you have a tortuous course, when it's A-long, when another expert, let's say like Dr. Rahman, has tried to wire it. It's very arrogant if I say, oh, I'm just going to go wire it. It doesn't matter that someone else tried. So in these cases, you might want to consider knuckle or other strategies. So penetrative wires tend to go straight. Knuckles tend to follow or stay in the architecture of the vessel. So again, to rehash, wire escalation, ADR, retrograde wire escalation, RDR. Now, you're going to use all these anatomic constraints to come up with a strategy. How does this all come together? So if you have an unambiguous proximal cap, a good target, you're going to start antegrade. And now the answer is no, you're going to go retrograde. If you have an interventional collateral, now you're going to go ADR. Now, if you're going to go retrograde and you try to wire it, or if it's very long and you already know I'm going to do a primary RDR case, you're going to do reverse card. So now, that's kind of the basics. Let's switch gears and say, should I even do this case? Do I know? Am I likely to succeed, etc.? So the granddaddy of all this is the JCTO score, which really is probably the most used term. So obviously, as you guys can see, the higher the JCTO score, the lower is your chance of success, and it goes anywhere from 0 to 5. Okay, so a tapered blunt, that's one of the ways you do it about the proximal cap, is a calcification. How's the angulation in the CTO body itself? Is it very long or is it not? And is it a reattempt or is it not? So each one gets 1 point. And the higher the JCTO score, the more complex it is. So again, like I said, the harder ones, 2+ are generally considered harder. 0, 1, you can probably wire it. And it really was a predictive, it was being well validated in multiple data sets. The key was, do I think I can wire this within 30 minutes or not? That really was the primary goal from which this whole thing was derived and then subsequently validated. And as you can see, the really difficult ones takes a long time to get across. Again, multiple CTO scores have not come about, so I'm not going to spend time on each one of these. but many of these are validated. This is from my friend Galassi in Italy. And this is a score that, again, I think has been validated a little bit. This is from Manos, Dr. Bilakis, and from the Minneapolis Heart Institute. And really, again, here, what makes it hard when you don't have an interventional collateral, when your proximal cap is ambiguous, you're dealing with a lot of tortuosity. Circs, we know in regular PCI is always hard. A Circ CTO is harder if it's a prior PCI. Now, each one of these gets a point. And the harder, like the more number of points, the more difficult it is. And again, I want to just switch gears and also tell you, when talking about collaterals, for those people that are just getting started, don't take a high-end epicardial. What you really want is a side branch-like connection with good favorable angles of entry and exit. That's what you're looking for when it's easy, right? And something not wicked tortuous. So the main things are, what's the size? How does it exit from the donor vessel? Because you got to be able to get in. How tortuous is it? You got to be able to wire it. And then here, from the CT Rector registry. But again, the long and short of it is that it's many of the same anatomical factors make it harder. So this is kind of a summary slide. You have multiple scores. Like I said, you've got the CL score, JCTO, progress, whatnot. I think the most well-known ones are the progress and the JCTO being the most popular one. But again, remember, these scores are not going to tell you about indication. I mean, it might tell you, should you try it or should you not? APCTO actually says if you have not done more than 200 CTOs, you probably shouldn't do anything more than a 0 or a 1, because your likelihood of success is pretty low unless you have a proctor. Now, to summarize what we've talked about thus far, I think I've taken about 15 minutes so far. You want to really review the angiogram, do it right the first time, and don't do ad hoc CTO PCIs. Now, this wasn't asked, but I think it's important. In CTO PCI, we are often referred to as cowboys. Oh, I did a 6-hour case. Nothing to be proud of. I mean, unless you were really balancing it. You don't want a 12 gray CTO case. You don't want a huge perf. Perforations are the #1 reason why people die when you do CTO PCI. Perfs are bad. Mortality overall is a little bit less than 1%, but you need to have this discussion with patients, all right? So, and it's also important to know what is going to put you at a higher risk for perf. Retrograde definitely does have a higher risk of complication. However, it doesn't mean you don't do retrogrades. It just means that if you're not done enough and then you're going to switch from antegrade to retrograde, you better be prepared to deal with complications. Again, probably not appropriate for the audience. You definitely don't want to do more than one CTO at the same setting. And if you are dealing with a post-bypass patient, you really want to know that perfs here are going to put you at a much higher risk. Again, CTO, progress CTO does tell you not only in terms of what your likelihood of success, but also your risk of complications, older patients, long lesions, retrograde, all right? So any time before you start doing a CTO, you need to know, what's the potential benefit? Why am I doing this? This is a patient with a lot of symptoms, large ischemic burden, and I'm trying to do something. Am I likely to succeed? What is my risk of complications and what's my risk of long-term complications? So I'm going to switch gears to talk about toolbox now. This is an entire talk by itself, so I'm just going to touch upon this. The long and short of it is be prepared before you start a CTO. Don't go with, I got a pilot 200, I'm just going to, you want to have guide extension catheters. We don't have trap liner yet, but you have telescope, guidezilla, guideliner, whatnot. You have dedicated balloons for trapping. We can use any balloon really for trapping. It's important when you start using CTO wires that you understand the function of the CTO wire. Do I want something that's going to, with a low tip load? Am I looking at a tapered proximal cap? And am I just trying to wire this? So that's very different. And am I trying to just cross the CTO with like an XTR or something? I just want good feedback. So in that case, I don't need a lot of tip load. I want good torque response. Now, the wires that we use for this are very different than the wires that we use for collateral crossing, where you want a low tip load, etc. So you got to marry the function of the wire to what is, the wire properties essentially. So this is a summary slide which I think is very good. So for microchannel tracking, you want to use one of the XT family series. Cyan black can be used, and for cap penetration, you want something with a lot of oomph. You could use a Conquest 820, a Stato, a Hornet, etc., or one of the Gaia series. Knuckle dissection, again, different properties. You're trying to knuckle it, so you can use the Mongo once we get it. Bandit once Teleflix launches it, XT family, the Fighter, or a Pilot 200. For re-entry, typically these days we just go Hornet 14 or a Stato. Retrograde crossing, again, I tend to use Seance a fair bit. XDR, when you're really looking at a super small channel, 203 almost as a default for, for epicardials, and Cyan black when you're just going to surf. And again, Samurai RC, unfortunately not been mentioned here. Externalization wires, the only thing we have right now is the RG3. So, but this is the kind of stuff that we could do these days. I mean, things which are, that's the kind of epicardial that, in fact, this is from a case from in Chennai that actually, again, before SUO 03, this would have been ridiculously hard. I actually had to use a dual lumen catheter to even get in to the collateral, then used a Caravel SUO 03, crossed it. And, again, this case was kind of a nightmare case because the angle of exit was really bad too, but successfully done. And that's a circ that's revascularized. Microcatheters, again, understand there are lots of microcatheters in India and Bangladesh. I think we can kind of just cut it down to the big ones, right? You have the Corsair Pro, that those are the big ones, and then your Fine Cross and Caravel, those are the small ones. We will be getting a lot more, and the playground's going to get a lot more crowded. But for now, I would say, when you're doing an epicardial, I tend to use Caravel. Turnpike LP is great when we get it. Corsair Pro XS is going to be fantastic when we get it. And again, Turnpike is going to be here with a whole family of microcatheters. But for now, Corsair Pro is probably my default for Antegrade. I still do use Fine Cross a fair bit. Dual lumen catheters, again, we don't have twin pass, but Suzuki is going to come to our country very shortly. It's probably going to be the best dual lumen catheter that we are going to have access to. Right now, the only thing that we have is Crusade. It's important that you learn how to use this. I'm not sure about which of the balloons that you have in your Cathlab, but it's always important that you know what is the lowest profile balloon you have, whether it's an Ikazuchi, whether it's a Re-Ray or a Sapphire 10 balloon, but do know, or a Nick Nano, whatnot, do know what's available. Plaque modification balloons. Wolverine was just launched and just used it in India for the first time. It's there. You have the angiosculpt, you have the flexdome still. Crossbars, I think, is being used increasingly less these days. It's used Antegrade. It's really just a control knuckle. I think I'm using it less and less these days, to be honest with you. And then, of course, the Stingray balloon, which is a dedicated re-entry catheter. Sorry about the voice. I was going to mute that. But it's 2 dots on a stiff wire that you want to get down. And then once you do that, really, you can have targeted re-entry from the subintimal space back in. So that's really the advantage. And that's kind of, I'm just going to zoom it if I can. Yeah, that's how it looks. So either it's going to be this port here, it's a proximal, or the mid port. So you can re-enter with incredible precision. Of course, you got to know your imaging. Laser is available in India. I think it's been launched in Bangladesh too, if I'm not mistaken. We're going to get the Rota Pro soon. So last month we just launched laser in India. So when you have wire across and nothing else will go, you could use that. Of course, we need to know how to use hemodynamics and when to do it. Be prepared for complications because they will inevitably occur. If you're good friends with your Biotronic guy, if you can get a Papyrus stent, great. Otherwise, you still have Graftmaster. Have everything in a shelf so that you know where to look for stuff. Your pericardiocentesis kit, your microcatheter, your snares, whatnot. Really having the right tools is going to help improve efficiency. Try and avoid Me Too products. You don't have to have every wire that's there. For example, I don't stock Gaia once. I just have 3s. Sometimes I have 2s. I tend to keep XTRs. I don't use a lot of XTAs because I mean the gram tip is 0.6 versus 1, very similar wires otherwise. So try to, pick your wires, be comfortable, and keep an inventory that you can manage. And so this was done. So I'm just gonna keep going. I don't know why it went back. Sorry, guys. I just added some of the stuff because initially I wasn't going to talk about the toolkit here, but I will. How many more minutes do I have, guys? Hello? Hey, guys, do I have time to show a case or do I not?
Yes. Yeah.
Okay. So,
Nice to hear. Okay.
Okay, maybe I'll try to wrap it in another 5 minutes. If you need me,
yes, sure. You 10
stop.
minutes.
Let me know anytime. I don't want to exceed my time.
You can continue
Sure.
for 10
Okay,
minutes.
good. So, I mean, this is a case that I think brings it all. Okay, thank you. Thank you very much. So, this is a patient who had a prior attempt, Cto Pc of the LED, unsuccessful. In fact, this was done last month. And the patient has like horrendous angina on good medical therapy. And his insurance, so I had to actually go to Apollo to do this case because they wouldn't accept the insurance at our hospital. But anyways, kind of a calcified, again, see, it's important that you set up your CTO to succeed. And here I kind of thought, well, not a big deal. I can probably wire this antegrade, famous last words. So it's important because, here I thought the proximal cap is visible. I know I got a plan. So didn't seem too long. I should be able to get this, right? It's calcification, but I can deal with that. So again, I'm not going to get into the discussion part because we don't have a lot of time. My plan was I'm going to start AWE. If it doesn't work, go retrograde. If it doesn't work, probably ADR. So interestingly, I did put in a microcatheter just for visualization because I don't like flying blind if I can avoid it. So I just couldn't penetrate. I've taken the stiffest wire. I've taken guide extension catheter. In fact, the stiffest wire they have, I have a Stato 40 in my shelf, but in Apollo, the one they had was your Confianza Pro 12. I just couldn't wire it. I mean, I just couldn't penetrate the proximal cap. So these are the options. And this was the time when laser still wasn't available in India. So I had to have something to penetrate the thing, and I couldn't. So I decided to go retrograde. So that's a Caravelle once again, and that's a Suo 03. So this is a high-end collateral. So this had to, it's a left to left collateral from the circ. So I was able to do that. And I'm like, all right, this is great. Why did without much difficulty? And I was able to get the Caravelle down. And I'm like, all right, this is great. And I thought I should be able to be done with this. So I did try retrograde wire escalation. Didn't work, so I quickly switched gears to a guide extension reverse card, which is you take a guide this is the Guidezilla, I think. You bring it into the LAD, and you take a wire. So okay, well this actually explains this, and this is courtesy of my friend Stefan. So wire, balloon, give yourself a target, and then your retrograde wire just enters it, and then you advance your retrograde microcatheter into the guide extension catheter. Interestingly, I wired it, but I couldn't get my retrograde. I couldn't get the retrograde microcatheter to cross the CTO segment. I mean, I tried really hard. I just couldn't do it. So then I said, all right, I'm going to come antegrade. So what I did was do what we call a tip in, where my retrograde wire, I just brought it into an antegrade microcatheter, and I still couldn't get my antegrade microcatheter to cross that segment. Remember the area where I was having difficulty penetrating? I just couldn't get any microcatheter. And unfortunately, we still don't have turnpike spiral. We didn't have Turner's goal. And I didn't want to take a Caravelle in a very calcific area because it has been known for the tip to break. I did try a retrograde fine cross, couldn't do it. So at this point, I thought, all right, my options are either to lose access for this, bring in a rotor wire and drill it, or but then I would have to lose access. And interestingly, it so happened that that day their rotor console didn't work either. So I'm like, okay, now I'm really in deep trouble. So this is from another case that I did in my hospital a while ago, which is what we call as an external cap crush. So you're dealing with a problem where you got the wire across, but I can't get anything else. So sometimes what you can do is come outside, go subintimal, balloon it, and that modifies it so that then you can actually deliver stuff down. And in fact, here once again, I was able to cross it once I did an external cap crush. Here, interestingly, I did external cap crush. So what do I mean by that? I go subintimal, like I just said. I ballooned across this area. I still couldn't advance either retro or anti. So now I'm like thinking, okay, what do I do now? So, so what I did was I've already crossed this area subintimal. I just couldn't cross it through lumen. So I just used my retrograde wire as a marker and then brought my Stingray balloon catheter down. And again, we've already seen this. So, so this is easy for me now. I'm from subintimal. I just use my retrograde wire as a target. That's a bad view. This is the right view. And I just did a stick and drive. And once this is done, it's all easy. It's a standard case. Now it's just a straightforward ADR. And just got my gear down, exchange for a workhorse wire, balloon, again, optimize with IVUS. And the key point, the reason I wanted to show you was this case actually made me go through a whole sequence of planning. So it's important that the indications are right, okay? Get the right tools, make sure you're prepared. This was in another hospital, and a couple of things that were supposed to be there weren't there. Make sure you have the skill sets to deal with this and go into the plan and be willing to switch from plan A to plan B if that's what is needed. Thank you very, very much. Open for any questions, or we can have the questions later.
Thank you so much, Dr. Orin. I think it is a great lecture for the fellows, budding cardiologists, not only them. I think we are the senior cardiologists also benefited your lecture. Thank you. It is also your lecture also enrich our archive also. We are a strong YouTube channel. Also there, everybody can see your lecture again and again. Before discussion, I like to request Mr. Saidur Rahman Khan, please continue your talk. Then you come back again discussion. Mr. Saidur Rahman, please.
Fantastic.
Start your session. Yeah.
You're saying something?
White paper.
Yeah. Blank. Right.
Yeah.
Okay.
Yes.
Okay. After Arun's lecture, I know that he is one of the stylish operator, CTO operator. So I really, while even hearing his CTO lectures, I usually go in, as if I'm running in the maze, and I couldn't find a way sometimes. My lecture is much more towards this integrate approach. And if you see all these cases, these are the cases which you usually face as a regular city operator, or the beginners may learn a little bit to understand that how we can do these things. So integrate Pci technique, which I actually like, because but you know that while talking about CTO, this business is very, very much tough, and even talking about this means it's better to go to the land of samurai and embrace the practice, to practice the harikiri. Sometimes it happens. Just I want to start in that way, that whether a CTO operator and a regular PC operator or just do a CTO or just a regular PC, is it same, or is it just in one way or another is like the regular one? No, the answer is no. Why? Because the basic difference between a regular and CTO PCI is you are dealing with a total occlusion with no free lumen. and that part you don't know. Unpredictable histology is there, and no classical modus operandi. So more reliance on the tactile response. This is very much important for CTO because you don't have any visual like other CTOs or like other PCIs. So, but you know that sight is the most important sense of human species, and it is absent here. So you have to depend on tactile response, and that's why CTO is a bit different from the regular PCI. How to treat a CTO? Lots of CTO scores and lots of algorithms. Already Arun has shown something. It's not like just pay, just love me, not like picking someone. You should have a plan. And scores, we have shown that lots of scores there, but like in bifurcation, Medina, like also in the CT, in case of CTO, the JCTO score is very, very much popular, other than the progress CTO, Richards, or Euro CTO scores are there. And algorithms, yeah, of course, dealing with the CTOs, the recent algorithms are a bit different from each other, as they are a bit different from each other. They are evolving constantly. So far, the world is, I can just precisely can tell that the North American and Europe CTO club algorithm and the AP CTO club algorithm, and these are the algorithms. It's a very busy algorithms are there. And among these algorithms is too much different, especially for integrate approach here, because three main questions are there with the primary approach, whether it will be integrate or retrograde. Is there the proximal cap ambiguous? Is the distal vessel of poor quality, or is there an intervention collaterals present? And the occlusion length is because there's a cutoff value like 20 millimeter, less than 20 or more than 20, but that one is not that much important nowadays because we have the DEAR strategy, like dissection and re-entry strategy, and combination of other factors. We have to think more for CTOs in integrate approach because of whether there is a severe calcification, you have tortuosity, you have length, and also the previous failure. And also the newer things is the role of IVUS guided entry. That's very much important. And also the parallel wire techniques and dissection re-entry with string systems have been included in the integrate approach. I love integrate approach because it is what Arun also said, that it's less complications. I tell, and that's why most of the common approaches in the world is still the integrate approach, especially the integrate wire escalation. So first, before going further deeper in the talk, just I'm on to share a case. This is in a CC is in a case where you can see that just after a left main, the LED is totally occluded, and you couldn't find out anything here. But and even when you have done the dual injections, also you can find it. And here, where is the LED ostium and where I will perforate the proximal cap? Is there any dimple or at least or something? Nothing is there. So here you have a real bad problem is there. So here what you can do, that you do the IVUS guided wearing just near to the proximal cap on a branch, which I have done, and then you have seen that that there is a cap is there, and by that cap with a just hydrophilic intermediate wire is, and along with the dual injections, I've been able to cross it very easily. Then it has become a very piece of cake, and the final angiographic picture was good. So this integrate preparation first is a philosophy. This philosophy is very much important. Overcoming the proximal cap ambiguity with IVUS is part of their integrate philosophy and our integrate philosophy also. Even if you plan to use retrograde, integrate preparation should be performed beforehand. And rationally for this is that integrate preparation first is because it reduces the time even for bailout retrograde, and it encourages doing directly to reverse card or removes the risks of single retrograde wire crossing in ostial lesions. So that's why the antegrade preparation is very much important, and that's why I'm talking about antegrade approach. What are the prerequisites for a successful CTO PCA, especially antegradely? We have to know the histology of the CTO. We have to know the physical characteristics of the wire and other hardwares. To choose the correct hardware according to the composition of the occlusion, need the wiring techniques we have to know, and also choosing the right strategy at the same time. About histology, it's a very busy slide. Just I want to say here that you may have a microchannel, especially in the relatively younger CTOs, and a CTO operators a delight that they will be easily penetrable by a soft polymer jacketed wire, but there are lots of microcapillaries may be present, and also in the CTO body and the segment will be intermingled with a very soft channels or soft or steep with collagen and elastic bands are there, or very hard along with calcium is there. So, and always you have to remember that proximal cap is tougher than the distal cap usually because of the hemodynamics, abnormal hemodynamics in CTOs. And these are the composition. You can see that the plaques and on all these lumens, how it looks the CTO vessel in cross section. So name it in different way. The new CTO ARC announcer, because I love this new CTO ARC document, which has been published very recently. We are using all the time subintimal, subadventitial, intramural, or these terms. They are telling that it's better to tell extra plaque and interplaque, because whether we are in the through the plaque or we are going to extra plaque, especially for ADR. So it's not bad to understand, to see these pictures here, and you can see here that this is extra plaque is going, and then it is truly interplaque. So by these two way, you can grow antegradely also. Even in the IVUS, you can make it show that whether you're extra plaque or interplaque. Then comes to the physical characteristics of the wiring. You know that all the wires have these sort of 8 qualities, and all these qualities the companies are trying their hard to make different types of words to just have give us that the confidence that which wire can do what. And especially we have to know also the tip load. What is the tip load of that wire, whether the tip is blunt or tapered, and the core composition, whether it is a composite core or single core, and whether the wire is polymer coated, hydrophilic or hydrophobic or non-coated. These factors are very much important for the physical characteristics of the wire, and by which way which wire you can choose. And you see that the lots of wires, they're starting from the low gram weight or low penetration force wires to medium with the high gram weight, or these are the with the tapered or non-polymer or polymer jacketed wires, including filter groups, pilot groups, and the Gaia series, and also the older and the very familiar names like Confianza, Miracles. These are the wires of the high penetration force wires. And so among these hundreds of wires, so we have to keep all these wires in our shelf for a CTO to become a CTO operator in a Cathlab. That's not possible, but at least you should have some low gram weight filter XT or filter groups. You have some medium weight wires like Pilot, PT2 Boston's, and Gaia's 1, and also the Gaia's whole series if you can, and also the high gram weight or high penetration force wires like Confianza, Miracle, and obviously the Xion Blue and Xion Black if you go for the retrograde approach. And these are the techniques for the antegrade wire escalation. The 4 basic techniques are there. There's a drilling, penetrating, or sliding techniques, and push on track or push on torque, like with the through as it works by the Gaia series of wires. So this is the sliding is the most easier one, and for the younger CTOs is very much helpful. And the microcatheters, already the Arun has said that this is very much important for a CTO, is essential part for antegrade approach very much. And this support is even by the over the wire balloon. You can also if you don't have the microcatheter. And here I want to show in between the another case is a 62-year male and with a prior ammonia back, and you can see that the CTO is totally RCA CTO is a devastating CTO because it has a tapered end, but that's severely diffusely diseased, and also you can anticipate from the distal retrograde. The distal retrograde is very very much poor, and also showing and possible another CTO distally. It may be there. So we have gone with a small microcatheter injection, and we've helped with the help of the microcatheter, and also by a hydrophilic wear, we have tried to cross, and we have crossed a bit, and then later on took the microcatheter there with 0.5 milliliter of injection contrast, so that we are in the true luminal knot. And then after that, the wearing has been done, and it has been stuck in the distal part. And so we have push the microcatheter distally, and we have seen there also another CTO is waiting for me, and that one has also very much hard to cross, but with some way taking the another hydrophilic wear, we have been able to cross it, and then we have stented it and deployed the 3 overlapping stands, and the final picture you can see here is not wet. So here's the importance of the microcatheter. And while preparing for antegrade techniques to apply, few important pearls to be meticulously maintained upfront. These are the dual injection. He has told, Dr. Arun has touched a little bit, like in before PCI and of course during PCI. And especially what is very much important to tell, I want to tell for the younger fellows, that dual injection is very much important before PCI to plan, because it will reveal that whether the CTO is, sometimes you can see that dual injection, there's not a total occlusion. And in some cases, it's really, really where you can see the stump. And during PCI, it allows visualization of the guidewire position. Even if there are lateral collaterals at baseline, even it helps for dual injections. While using the ADR, or the antegrade and dissection and reentry, the antegrade contrast injections should not give that much because it causes hematoma. So how to go for a dual injection? Few important tips there, that use low magnifications, and better to introduce the RCA guide catheter first rather than the left, and then obtain a long cine acquisition, inject the donor vessel first, and then that supplies the territory distal to the CTO, then the feeder vessel, and avoid using a sidal guide catheter on the donor, and then it will be helpful. Which vascular access will apply? I'm a radialist, so I usually use the vascular access as a radial, and for dual injection, the biradial or radial ulnar, or you can use also the radiofemoral, or you can use the bifemoral. None of these approaches was shown to be superior to one another. And gut catheter support is also an important issue. These are the pearls for integrated approach. You have to prepare for all these things, and you have to think of these things from before. Larger French gut catheters by 7 or 8 Frenches for lots of complicated procedures. 6F is also compatible nowadays with almost CTU devices. For better support, more coaxials, and use different types of loops you can use there. Guide extension catheter if needed, and child and mother is sometimes necessary. But always to be remembered, for the sake of support, not to make out osteal dissection. That is not that much manipulation while thinking of the city only. And undersizing nowadays in Japan is very much important. So even I sometimes use the 5 French guide catheter with different like alpha loops or gamma loops or epsilon loops, gives very good active support, and you can do CTO by that way. So now comes to the procedure proper, the antegrade text. It includes in general the wire escalation, dissection and reentry, and the parallel wiring. This is from the APC2 has given too much emphasis on the parallel wiring. And whatever the approach, the basic principle here is that you have to perforate the proximal fibrous cap, traversing the length of the CTO, that is the CTO body, piercing the distal cap, and come to the true to true lumen entry distally, and the job is done. And this is the way that the proximal cap, the CTO body and distal cap, how if you have visible channels, then channel you have, then you can take a low penetration force wear, but you have a tapered one proximal cap, then also the low penetration force wear. If it is blunt, then you have to take intermediate or a high penetration wears. You can escalate the wearing. And after in CTO body, it's better to go with a, rather than has been used to puncture the proximal cap, but it's better to change with a low penetration force wire to cross the CTO body in antegrade approach. And for distal cap, again, you can escalate the wear from softer to harder one if the distal cap is really problematic. While perforating the proximal fibrous cap, the stump should be evaluated as best we can by any means, like multiple orthogonal views, pre-procedural CTCA is sometimes very much helpful, and dual injection, obviously what I have said, and IVUS also I have shown one case there. And if the stump is built, seasoned operator looks for a, but all the time, if for a seasoned operator, for a CTO, while seeing all the views, always looks for a dimple, and sometimes you can get dimple when apparently it looks blunt or ambiguous. And for the proximal fibrous cap, while perforating, an operator should be prepared for antegrade loose tissue tracking, easy to resolve as situ is younger. Antegrade intimal plaque tracking relies on plaque morphology. For interplaque wearing, a subintimal entrance is a distinct possibility. Antegrade subintimal or extraplaque tracking is also needs what we may call dissection and reentry, and many spatial hardwares like crossbow stingray, which already Dr. Arun has shown also, or parallel wire techniques you can use. This is another case where you can see that it is a total ISO and the stump is almost blunt, and also retrograde from RCA is also showing that the almost half of the stentor segment is totally occluded, and we have taken intermediate hydrophilic wire with the microcatheter support, and then later on it has been crossed easily, and we have been able to do that one. And this blunt cap case is a SVG, totally occluded. To treat the SVGs also, we have taken the Gaia where, especially the Gaia third, it behaved whale, took microchannels up to the distal true lumens, and then this we need lots of manipulations with the balloons, but in the long run it has been successful. So if top proximal cap, which we see regularly, the top proximal cap presents two barriers to antegrade preparation, like inability to pass a wire or inability to pass any device. And ways to resolve is, there is a tree-like approach here that you have done better angiography. You can also do the CT angiography to see how much it is, and you can do the IVUS. And if all this, and the most important was the procedure is the move the cap, and it's like scratch and go technique, base technique, or Carlino technique. So these three things is the base is the balloon assisted subintimal entry, is a taken workhorse skyward first, then balloon the proximal vessel 1:1, and to make minor dissections proximally, take a polymer jacketed wire by microcatheter, knuckle it, and wire will re-enter to the distal to the CTO. But always we have to remember the dissection may be more, can extend, small perforation may happen, and wire lacking may not happen sometimes. If you take the scratch and go, it will be microcatheter based, 1 to 2 millimeter into push the microcatheter a little bit with a high penetration force wire, and then like the same way the knuckle, and then they do the case. And in Carlino also, then 1.5 to 1 millimeter contrast injection you will give, make some macro channel dissection plane there, and a small dissection plane, and then you can go with wire. But if you wire crossed, but balloon is not crossing, like this situation happens, and here crossed, the main I think I'm getting some noise here. So the main reason for failure of CT intervention is inability to cross the occlusion with a guide wire. That's true. But if the guide wire has been crossed, but balloon cannot cross the lesion after successful guide wire crossing in antegrade approach, and confirmation of guide wire placement into distal true lumen has been confirmed, but nothing is crossing there. It is about 6 to 9% of the situation we have to phrase in that way. And here, very interesting thing that's very much important to remember always, that there are lots of approaches. It's really taken from the Korean journals also. If it is uncrossable and you have inadequate supports, then you have to take the larger guide. So to make a very good support of the guide catheter, either by a guide catheter extension, or you have to take a balloon anchoring techniques like this. And also you can take the microcatheters, and if it is even unsuccessful, then go for a granuloplasty. And if it is even unsuccessful, then we have to take the laser or rotablation, and or we have to switch the techniques to go for crossbows and stingray. And also there are crowbar or seesaw balloon wiring techniques are there. So this is the case like this. You see that the CTO is very, very dangerous with the bearded appearance. I hate the bearded appearance and I dislike the CTO with the bearded appearance. Means it's really very hard. And you see that all the injections have been done. But with my surprise, the wire has been crossed very easily with a hydrophilic wire. So the channel was there, hidden channel was there. But with my surprise, everything, whatever we have taken, the balloon was not crossing. So we have to do this granuloplasty here, because even 1.2, the smallest profile balloon was not crossing. So we have taken granuloplasty with a smaller profile balloon, 1.25. And after that, everything was possible. And then if the wire goes extra plaque, then comes to the parallel wiring and dissection and re-entry, these two techniques. This is very much important. Always you have to know how to go from extra plaque to intraplaque. And this parallel wiring is when use of the parallel wire techniques and IVAS guided wiring are included as options in the Antegrade arm of the main algorithm, especially when the device-based reentry are not in hand or heavy calcification and tortuosity are there. This parallel wiring is that it is the initial guide wire is left in place as a marker and to obstruct the false channel. And then the second stiffer wire supported by microcatheter is then advanced parallel to the first wire until the point of the first wire is thought to have deviated. And this is often detectable by subtle inflection in the course of the first wire. The second wire is then directed towards the distal target and advanced into the true lumen. The Gaia series of wires are particularly very much effective for this sort of, because it has very high torque control. But if these are fails, then you have to go take the help of the device-based techniques. So these are the diagrammatic views of the parallel wiring here. They've taken the microcatheter, wire has been in it will go to the extra plaque, not in the lumen. So we have taken another wire and it has been with the microcatheter support, and then it has gone to the true lumen. Or some way you can go for the seesaw techniques also, where two microcatheters you can use simultaneously. So it's a case where we have seen that this is, I couldn't put all the pictures like a parallel wiring, but I have done it as a parallel wire. So you see that the blonde stump is there and the wire has been in the dissection plane there. So we have taken, keeping that wire, ultimately we have done this wiring with a Gaia, and then that picture source has not been recorded. And then the IVAS has been done to see that whether we are where we are, whether all the way we are in the subintimal or extra plaque, not that much. So then the stenting has been done well, and final injection and the dual injection was perfect. So here also another important point which he likes sometimes to say, that don't forget the knuckle wiring thing. It's not only for the retrograde approach, even for the antegrade approach also. The major benefit of the knuckle wire is that it allows occluded segments to be negotiated rapidly with a low perforation risk, even in the presence of anatomic ambiguity. So use the knuckle tracks as the knuckle tracks a subintimal space. A mechanism for re-entry into the true lumen distal to the octosemid is required, and sometimes you may need the stingray there after knuckle wiring. But all the time, which wires can be knuckled? Well, there's polymer jacketed guide wires like the filter groups, the pilots, and also the Gaia second wire can be effectively knuckled as possible. But the knuckle should be as small as possible. And this is the way how you can use the knuckle wire here. And not all the time you need the stingray. If you go to the distal true lumen, then you are very much happy to do the stenting. So this is one of the cases which has been as a live case there. And I was a little bit traumatized to do the double CTO in the LCX and LED. And the LED was really, really angulated, and it was not crossing at all. So we've taken the guy's second wire, later on up escalation of the wires, and then this knuckle. This is not a good knuckle. I'm not advocating anybody to do that one, but I was desperate at that time because nothing was working. And then you see the dissection plane is there, and after stenting, this sort of knuckles sometimes, and the LCX also easily wired by the Gaia first, but you see that all the pictures are there is and this is another case with the knuckle. Is you can see that this place is a blunt ambiguous proximal cap, and here also you can see the distal part of the thing through the dual injection. Then the Gaia first we have taken, then it has been escalated to Gaia second, and then you see that I am doing a little bit with a push and torque and advanced techniques, but yet it was not crossing. Then the knuckle has been happened a bit subintimal space, and then later on in the true lumen, and the stenting was done. So this is the way, and the same way, this is also another one where filter extruder has been knuckled well here, because I knew that this is a bend, high torque, and calcified place. And here the filter extruder has been knuckled well, and it has gone in the true lumen, and then the stenting was good. So this is the final picture there. So dissection and re-entry, it's the idea is a technique where the guide wire and all other intentionally pass into dissection plane before re-entering the distal true lumen. So our main purpose, we have to go to the distal true lumen. It's a two main indications. First is the primary strategy for crossing longer complex CTOs, or secondly as a bailout following inadvertent extra plaque wiring passage which is gone, which is not at all going in the true lumen. And then there, in case of Antegrade approach, you have to go for this dedicated Antegrade dissection re-entry. And here, these are the when it will be a primary strategy. If the well-defined proximal cap, you have large caliber distal vessel, no large side branch at the distal cap, length is more than 20, and lack of good intervention collaterals is there. And you know that this is wire-based or divide-based DR is there. This is a very busy slide, I'm not going to tell. These are the techniques with the wire-based like star, and here knuckled polymer-coated wire is advanced until it spontaneously enters the true lumen, and then extensive shearing and occlusion of the side branch may occur if knuckle is not that much good. And then comes to the mini star, and then also the last but least is not that much preferable nowadays, because the studies are telling the complete septal and other branches are lost sometimes. And device based, already the boss Arun is the boss for this one, is the crossbows and the stingray and the recross devices. These are the devices, and Brilakis has shown this way, this algorithm, that how you can use the crossbows and how it will be handled in this way. And this is the picture that the crossbows is crossing in the subintimally, so that you can put the stringer there, and after that stringer with the correct position at the distal lumen, and then it has been crossed. And the another one is very much interesting, but sometimes we do it even inadvertently, that the subintimal plaque SPM or plaque modification, intentionally dilating the subintimal space during unsuccessful Cto Pci to facilitate flow through the dissection planes and improve success of repeat Pci items, especially 6 to 8 weeks after. Then you will see some channels, macro channels has been appeared. But while doing that one, it's better to not to give too much Antegrade injections after ACM, even not at all, because that will cause the hematoma, extension of the hematoma. So complication outcomes following ADR is contemporary resist is showing low complication rates from Antegrade Cto Pci, especially with the ADR also, except in the last star techniques, which causes lead to some concern with poorer outcomes. But vessel healing and stent coverage in the subintimal, even in the subintimal tracking, to be unaffected by the extra plaque stenting. That is also been told. So CT intervention is a fatigue. Most important to remember is when to stop. It's very much important. If the procedure time is more than 3 hours, if more than at least 4 into EGFR of contrast has been used, or the radiation dose is 5 gray air karma, unless the procedure is well advanced, means that already you have crossed the wire. In that case, you don't need to think of that 5 gray air karma. But if it is not at all crossing and you're taking too much time, it's better to stop there. And you have to know that stop. So to wrap up, is say that I want to make it a lot more philosophical, is that Cto Pc Antegrade Cto Pci is getting more perfectionist approaches, wire catheter and adjunct accessories are evolving, and success is jumping from 70 to 90% along with the retrograde approach, obviously. Considering less complications, CTO operators have to be best equipped with AWD, Antegrade wire escalation techniques, and also the ADR. And from philosophical perspective, to be, which I tell to my fellows also, to be a CTO operator needs some spatial tactile ability, not it's very much spatial tactile ability you have to know, and also feel the wire most, and also extreme perseverance you have to. At the same time, you need to know when to stop, and that's the beauty. And if you can do that, I usually tell my fellows that CTO is like a beast, and to tame it like Belle in The Beauty and the Beast. And you know that if you have gentle touch, years of perseverance, meticulous tactile and visual perfection, you know that the beast can bow towards you like anything. Thanks anyway for patience hearing in the midst of dark, light, hope, and despair like CTO.
Thank you, Professor Saidur Rahman. You are
I think
another stylist. You are another stylist speaker also. A nice elaborate presentation, helpful for the juniors, especially they learn a lot from the ABC of CTO technique. I'm requesting Professor Abdul Chowdhury, sir. Do you hear me? The chairman of IPDI. Professor Abdul Chowdhury, sir. Do you hear me? Professor Abdul Chowdhury, sir. Do you hear me?
Can you, are you listening to me? Can you hear me?
Hello. I think it's
Hello,
out of
can
network.
you hear me?
Yes, sir. Yes, sir. We are hearing you, sir.
Hello.
Hello.
Can you hear?
We are here, sir. Yeah, clear, sir.
Uh,
Dr. Arun also here, sir. Dr. Arun Kalyanasundaram also here, sir.
really missed some part of your lecture. I was a little bit late joining. I was on the way. As Saidur has said, both of you are actually very stylish speaker, both in your job and also in your presentation. And you know, when you present these things, I feel I'm quite old. I'm getting older. And for the young ones, you have to have lots of patience and the perseverance to go for CTO. I often send my CTO patient to Saidur's way. Well, I'm not going to bother with this CTO because it's looking too dangerous for me. And you have to have a very well-equipped Cathlab for doing the job you want to do. As Arun has said, you have to have a plan A, plan B, or plan C. Or you should know when to stop, when you think it's beyond you. If you do not have the necessary equipment, it's very difficult to do the CTO. And ad hoc CTO, as you have said, is better not be tried. We should have clearly go through the angiogram, find out which way I'm going to do, which method I'm going to try, and whether I have the necessary equipment, then go for it. Thank you both of the speakers. You really have presented so nicely, and it will be very helpful for the all of us. Thank you again.
I heard Dr. Timir Pal from USA is here. Dr. Timir, do you hear me?
Yeah, I can hear you.
Thank you. Thank you for joining with us. Yeah.
Oh, no, thanks for inviting. It's a great presentations by both Arun and Dr. Saidur Rahman. I mean, that is too detailed, and both are very expert CTO operators. I have only one or two questions, not related to the techniques, but I think that my comments is the indication for the CTO. You have to really pay attention to what kind of patients will get benefit. You know, very recently we just published a paper including 16 studies, more than 11,000 patients, meta-analysis, not many randomized trial, only very few, and mostly observational studies. But we showed that there is no difference between any outcomes, like MACE outcomes, mortality, whatever you name it, between the two groups. So I think that if patients are on maximum medical management, real maximum medical management, and if we discuss the risk and benefits and those kind of patients is only get benefit the opening the CTOs. Like what kind of patients will get benefit? That's the most important question, number one. And number two is, I think that unless it's otherwise indicated, we should do a viability study for all CTO before the CTO operator, or you can do at least the stress test to make sure how big is the territories involved. Will it really get benefits? So those are my specific comments on CTO PCI.
Dr. Arun Sundaram. Dr. Arun. Dr. Arun here.
Yeah, Dr. Mohsin, by this time, Dr.
Dr. Arun is
Hey,
here.
can you hear me?
Yes.
Guys?
Yes, sure.
Yeah, hi.
Yes,
Can you hear
yes,
me?
sure.
Yeah.
Yes.
So I was just saying, I mean, I think there's a little bit of lag, so I apologize. But I think those were very pertinent comments by Dr. Timir Paul. You know, we keep touting about the whole mortality benefit. I think, you know, it's really hard in today's day and age to justify any elective PCI with mortality benefit, absolute certainty. Well, that being said, you know, one of the things that we notice in many parts of the world, including our own, at relieving angina with PCI. So I think it is important that we pick patients very appropriately. So, I mean, one of the things, again, I'm not triple anti-anginal therapy who have had bypass surgery, they just have a lima that's staying open. The rest is all closed and they're being told, you're 55, it's okay, just walk slow. It's okay if you have chest pain, PARP, you know, just stop. So to me, but the errors of omission is also being something that's swept under the carpet. So there are lots of patients on good anginal therapy that still get horrendous symptoms. That's definitely appropriate in any part of the world. I think the point about viability, I think it's very important. When we do say that, hey, there's a CTO and should it be open? Now, if you are not sure about viability, say you have a 30% EF, LAD has been occluded for a while, then I think it is important that we do viability. When you have normal ejection fraction, let's say you have an EF of 60 or 55, it's very likely that the myocardium is viable. Otherwise, you're not going to have normal EF. So should we do it across the board? I'm not sure. But for the low impaired EF, for sure, I think it's important we assess viability. I do want to emphasize, not every CTO needs to be opened, number one. Number two, I think I loved Dr. Saidur's point about know when to stop. It's an elective procedure. It's okay to come back. It's okay to call a friend. It's okay to refer to someone else. You don't have to win every time. I think we should understand why we do it, when to do it, when to stop.
Yeah, Dr. Mohsin.
Yes, also Saidur Rahman.
Yeah,
Yes.
because I usually think, because I have I love doing CTO. That means that for the last 12, 15 years, I am just behind it. It's not just to be stylish or to be egoist or to be just like that I have to do CTO. It's not like that, because the most importantly, whether you are giving some benefits to the patient. So frankly speaking, why we are doing a PCI to a obtuse marginal branch, or why we are doing a PCI in a CCS settings, if you just think of the courage or beta or whatever the trials you're taking, then you will stop doing all the PCIs. But why you're doing it? Because patient is knocking your door because of relieving his angina, because that is the prior thing for the benefit of the year. Because we are not talking about the bypass surgery, why they're doing the graft, SVG, to a CTO LCX or CTO OM. Why? Because that graft has got a failure rate more than a stent sometimes, but they are doing it, and we are not questioning that one, because we know that they will tell that it will relieve the ischemia. But most importantly, these sort of CTOs, obviously the viability test, when you will do it when obviously the ejection fraction is lowered and you really don't know that the totally akinetic or totally aneurysmal segment of the LAD. So why you'll do the CTO of that case? You are not going to even go for a bypass surgery for that patients. Otherwise, you are not doing an aneurysmectomy or something else, some special devices you don't put, then what's the benefit of doing that one other than have a very good GDMT? But another thing is that the most importantly, what I'm telling again and again, because all the time concerning CTO, these questions arises, like you have double jeopardy. You know that only 4 are cities in CTO, only 4 are cities: Explore, Euro CTO, Decision CTO, Impactor CTO. Only 4 are cities and all are registries. Some and all these registries are so different. Some have used it against the mortality benefit of the CTO, that they didn't put the stanting, they have taken the multivessel disease, and they have they've included the patients with the CTO PCI. It's not like this. You should have very precise CTO RCTs. Until and unless we can't end up with that way. If we can do a CTO OM, CTO RCA, CTO PDA grafting, why we can't do a CTO PCI? Obviously, if it will relieve angina, no doubt about it, whatever the resistors, multiple resistors, meta-analyses, and also this RCTs are telling that, yeah, it is helping. It is relieving the ischemia. It is relieving the angina. So that is one thing. And another thing is that double jeopardy, the most important thing, that your LED, your RC is totally occluded, and LED is supplying the RCA by collaterals. And anytime when the LED will be occluded by a thrombus or a STMI will happen, you will see this patient will come with ejection fraction 30% within 3 to 6 hours. You will see that patient has been hemodynamically that much devastated, which you didn't expect that one. So whether you leave that CTO from before, if when you knew that there is a CTO RCA, and you can easily open that on without that much complication rates nowadays. So this sort of double jeopardy to be prevent. So I can tell there is nothing to say here, because until and unless there are true trials, true RCTs are there, forget about the meta-analysis, because they are really different inclusion criteria there. So I'm differing in that way.
Thank you, Sajid Rahman. Thank you. Thank you. I think chest pain or any symptomatic relief, and also
So Mohsin is muted. Mohsin sir, we can't hear you.
Prof?
Close correct. Wadud can't hear you.
Dr. Arun, can you hear me?
Yeah.
Now we can hear.
Yes,
Hello?
we can now. Yep. We can hear you.
The net is very difficult.
Yeah, Wadud bhai, you can hear you.
My question is, when the young starts with a CTO, which sort of lesion they should be going for initially? Because initial success will encourage them to go for more, but they should be very choosy regarding that. Please give some guidelines to the youngsters.
I think, in fact, that's a fantastic question. And in fact, I have a whole talk on how do you begin the whole CTO stuff. I mean, I think, it's fair to yourself, your institution, and to the patient if you think you have a pretty reasonable chance of success and a very low likelihood of complication. So, in fact, if you go by the APCT algorithm recommendations, they kind of pretty much say stick to the zeros and ones. Now, if you are, I would say when you get started with any CTO, and depending on where you are on the learning curve, obviously we have done lots of complex work. If you're a rota, this guy, and you want to just do it on your own, I think, again, prudent case selection. But if you're just getting started with the fellows or the first 5 years post-fellowship, etc., I mean, we still do have proctorships. I think it's always a good idea to get another. I mean, it doesn't have to be formal. Get a more experienced colleague in on the case for starters. Number two, make sure indication is rock solid, because the worst thing that you want is, hey, I've seen a CTO, I'm going to do something, something happens, it doesn't work. People are going to get really upset if you didn't choose your case properly. Now, that's number two. Number three is pick something that, you think you have a decent chance. So, an unambiguous cap, a decent landing zone, nothing too long, because before you start getting into ADRs and base and retrograde, etc., you have to learn how to use microcatheters. You have to get a good feel of, this is what a Gaia feels like. This is what Pilot 200 feels like. This is what my Confianza Pro 12 feels like. You need to get comfort with these things before you start doing more, more of the complex stuff. So I would pick a case where you think, all right, I think I can wire this. It's not, I mean, even start with functional occlusions, right? I mean, you want to get a feel for the XTR. So, and you're absolutely right. You don't want complications, and you want to get like a good track record of success. You don't have to do every CTO that comes across your way. And, but I mean, again, you still have to refer them or get them taken care of. But I would say pick ones where you have a probability of at least 80% success.
Yeah, Wadud bhai, can I be a little bit precise about this one? Wadud bhai, hello.
Dr. Saidur, please go ahead.
Of course.
Just anatomically, because anatomically, from the anatomy of the CTO, for the fellows, what I can tell, just try to see that whether the CTO is, according to the history, looks like a CTO, and according to the history, it's not that much a old CTO. You sometimes can predict that one, like a younger CTO. So younger CTOs you can start first. So younger CTOs means like 6 months before prior MI, 6 months before LED is occluded, or prior MI 6 months before inferior MI. So these are the cases, you can predict, because some of the cases you don't know the history that much, because patient is not giving you a history, especially those patients where you are seeing that ejection fraction is preserved. So ejection fraction is preserved means that you have CCS, that chronic coronary syndrome, and patient didn't even ever feel any sort of attack or any sort of feelings before, means that CTO has been happened for a longer time. So that CTO is usually harder. But you have an MI or history of MI there. So that sort of CTO first. Anatomically, the CTO segment, the proximal cap is tapered, and you can see a dimple or something like a nipple or something there. And that one you can choose first. You can pick up first to have a little success. And the second thing is, obviously, please don't feel it a burden that why I will make another channel, another access, why I will go for a dual access, dual injection. Please don't do that one, because do a dual access. It doesn't matter for that patients that much, but it will give you so much details information. And also you have to know how to have a very good dual injection picture, which I have told, like donor first and then the feeder vessel, and how you'll do that one. That one is very important. And these two things can help you boost up doing and starting a CTO.
Great points, guys.
Can I add something?
Along with the tapered tip.
Mohsin, can I add something?
Dr. Arun.
Yeah.
Arun, please. Dr. Arun, please.
No, I was just saying, like, I mean, those were beautiful points by Dr. Saidur. And I'll just say, don't pick like, 30 millimeters or 40 mil. Pick like tapered proximal cap. If you're looking at anatomic stuff, lack of calcification would be very helpful. And short CTOs. I mean, if you're cherry picking your cases, those would be your highest likelihood of success. Hey guys, there are 2 questions that have popped up. I mean, I don't know if Dr. Saidur wants to take them on, or, is there any association between CTO size to select dissection reentry strategy? I mean, mostly the algorithms would say very long lesions, the long plus ones. Yeah, you might want to consider dissection reentry. Hybrid defined it as more than 20 millimeters, but a very functional definition is, I mean, if you think you can wire it, great. If you don't think you can, or someone else has tried it, failed with an ambiguous course, tortuosity, extreme calcification, those would be favorable for dissection reentry. And then there's another interesting question about the role of CT angiography in planning a procedure. So maybe Dr. Saidur can take it, and then I can give my 2 cents.
Yeah, because I already have shown a case that where I have shown you a CT image, the CTCA image there, that is CT angiogram image there, because especially the CTO, you want to all of these things, you know, the psychology, the back psychology, that I want to be successful, first thing. So you have to have a very meticulous plan, and it will be a little bit costly if the patient can provide, because still in our countries, like the Medicare or Medicaids are not present here. So even whatever the indications are there written in the books, we can't do that in that way. But if it's possible, then start with this sort of thing. A good CTCA will help you a lot to see the channels, and dual injection, again and again, I'm telling you, the dual injections, very properly doing a dual injections, and the CTCA. Of course, not for all the cases the dual injection, because if you have ipsilateral collaterals, not that much retrograde collaterals, that the dual injection is not going to help. These are some special scenarios, but other than that, CTCA will help you to see, especially what Dr. Arun was telling, the calcifications what they are, because in the CTO body, you don't know what is inside. It's like a maze. It's something like you don't know, like tough fibrous bands, collagen bands, and in between that there are channels. So where will go sleep in between them? Not, but I need to puncture that fibrous band rather than that in between channels, because that channel is going nowhere. But we can't see that one, so we were going in that way. So in that case, the CTCA will help you a lot.
Thank you. Dr. Abdul Jamil. Dr. Abdullah
Yes.
Jamil. Yes.
Yes. Thank you for arranging such a nice symposium, especially the 2 speakers who those who elaborately pointed out. One thing I just want to mention about the new beginner who are trying to do CTO. First, choosing the vessel. Please avoid circumflex and OM CTO for starting the CTO for the first time, as because this vessel is very notorious vessel, perforation and arrhythmia, all these complications are very common in circumflex and OM vessels. So better to start with LAD or RCA with a short lesion, what Dr. Arun has pointed out, and choosing the wires and everything. Another thing is there should be backup. So such that there is every chance of perforation, so one should have covered stent in hand in the Cathlab, and also for in certain cases might require emergency surgery, so surgical backup is also necessary for doing CTO.
Thank you.
Thank you.
Lots of our young colleagues also here. Dr. Abdul Manjur, he's from Khulna. Dr. Manjur, do you hear me? Dr. Manjur, do you hear me?
Yes, sir, I can hear you.
And Dr. Arun, he's the remote area from Dhaka. He's the Khulna. He's very nice doing cardiologist. Dr. Abdul Manjur, please ask your question.
Yes, sir. Thank you,
Any
sir.
question? Any question?
So-
Yeah.
Okay. Thank you, sir. Thank you for nice presentation. Though routinely I didn't start CTO, but I actually after having full logistics, but I will start it. The one question, Dr. Arun, during primary PCI, if you got a CTO, what will your strategy actually say? Thank you. During primary PCI, if you get a CTO lesion, so suppose acute and chronic, so what will I do, or what will I have to wait, or what will I have to try to open the lesion?
So No, I think that's always a conundrum. That's a great question. So just to understand it correctly, you're talking about a non-culprit vessel or the culprit vessel itself being a CTO?
Yeah, I'm talking about culprit vessel because suppose with the in the acute MI, I have got a patient and I did this, there is a mid CTO but proximal acute lesion. So what will be during anterior?
I mean, I think really depends on the clinical situation, right? I mean, let us say as in your example. Now, if you are dealing with let's say a proximal, as long as I got good flow. I mean, the short answer, let me put it this way. Let's say you opened up the culprit, you have kind of restored hemodynamics, things are settling down, ECG settling down, patient is pain free. I still am in the kind of my take home for primary angioplasty is do what's needed, stabilize the patient, restore myocardial flow, and let us say in the distal part, if you do have an incidental CTO which is getting collateralized, I'm going to live to fight another day. Because I mean, even during COVID times, even in India, I've been doing primary PCI, pretty much 24/7. So my take home is like, I mean, if you had to, you would, but you really don't want to do it in the middle of the night if you can avoid it. And always, CTOs is a different animal. The risk benefit ratio is different. You're going to have a conversation with the patient. And finally, I think in Bangladesh and India, the reality is you got to give them a cost. I can't open up like, a dozen wires and whatever and my microcatheter. So as long as the patient is clinically stable, ECG is settled, I would stop.
Thank you, sir.
Thank you. Another promising cardiologist, Dr. Arifur Rahman. Dr. Arifur Rahman Shajol, any question for
Hello,
Dr.
sir.
Arun? Yeah.
At first, I'd like to thank Dr. Arun and Dr. Saidur Rahman, sir, for a brilliant lecture. Operators like me, they are the most benefited group, I think, from this program, because we are started doing all sort of complex cases, and we want learning and the experience. We want to know your experiences from you. The thing we have learned today, definitely it will help our practice, and definitely will be benefited. And we'll of course we will keep all the points in our mind before we start a CTO cases. So thank you, sir. Thank you again.
Dr. Choin Singha, Dr. Choin Singha, do you hear me?
Yes, sir. Thank you very much, sir. Sir,
this is from Dr. Arun or Saidur. Anything?
This is a great lecture for us, for like our junior fellows. Sir, I have one simple question. As the beginning, which approach we should go first? Though sometimes the lesion demands the different approach, but whether we should go antegrade or retrograde, or which approach we will go? Thank you,
Absolutely antegrade. I mean, unless you're really comfortable with microcatheters, wires, etc. I mean, honestly, we're just getting started. In fact, there are about 9 steps in retrograde. You ideally should get a proctor. You really want to get comfortable with antegrade before you even think about retrograde. And retrograde, I would say, patent graft or septal way before you touch an epicardial. So there's a definite sequence in which you approach it. I think Dr. Saidur would pretty much agree with that.
Not even in a night dead dream or night dream, please don't think of retrograde approach initially or a planet. First, be sure that you are feeling the wires and you are feeling the CTO itself properly, because not all the CTOs look simple CTO, but you will see that it ended up with some sort of such a scenario that you will just come out and you will say what I have done. So first you will have to be very much with the like 80% success in antegrade approach, and then you will go for rest 10% for the retrograde approach. Isn't it, Dr. Arun?
Absolutely. I agree.
I have a few comments or question for Dr. Arun. How will you start CTO program in a Cathlab, like a beginner in the outside of city, Dhaka city or outside capital? How a center build up a CTO program or CTO team in a center? How do you experience or you share with the fellows?
So you're talking about how do you build a CTO team in a tier 2 city, right? So, I mean, I mean, there's got to be a plan. I mean, obviously, the best way is to line up some cases. The good things about CTOs are they are elective. So line up a couple of cases, make sure you're stuck. I mean, there's an entire talk on how do you build a program, but the nuts and bolts are, you know, get administrative support, because I mean, obviously, if you're the chief or whatever, and you know, make sure you have some budget allocated for it, line up the cases. If possible, get a proctor. I mean, ideally, yes, you should get a proctor if you're going to do it. Make sure you have all the stuff that you need, like, I mean, your microcatheters, the whole CTO card talk that we gave. Make sure you have enough of those. And I mean, if you're just starting off, I would still say pick cases that are not ridiculously hard, because even for your program, for your own colleagues, I mean, you're going to have a lot of naysayers that say, why are you doing this? God, you occupied the lab for 3 hours, 5 hours, whatever. So pick cases where, you know, the patient would clearly benefit, not super crazy patient. I mean, like super crazy hard patients. You know, make sure you get administrative support, a good CTO card, and ideally a proctor.
I want to ask another question to Dr. Arun.
I want to add here. For this question for Mohsin, for this, because the thing is that if you really want team also, these are the things what Dr. Arun is telling according to the books or written in that way. But philosophically, what is important there? Like you have 2 fellows, one of them doesn't like that much to be by my side 3 hours. No, getting tired, moving aside, it's not going to happen. Some sort of indications of like that one, you are not, that he should not be in my team. The scrub nurse is feeling like dizzy. So, you know, that there's some sort of negative sense. When you are almost in the verge of success, even at that time, somebody is pulling you, that sort of people will not be there. Your team should have that sort of enthusiastic, not like devastating, that you will perforate, you'll do everything, egoistic, not like that one, but very perseverance, loving people, CTO loving people. They want to see that a CTO is flowing integrately very beautifully, and they will smile. And after 3 hours even standing there, that sort of people, I usually ask that whether you are really want in that way to see these things, then I choose those fellows, yeah, you will be with me. I can help you to see that how a Cto Pci can be done.
Thank you.
That is also another part, psychological part.
No, that's a great point. You don't want a lot of negative energy around in the lab, for
Yep.
sure. Yeah.
Thank you.
I want to ask a question to Dr.
Yeah,
Arun, sir.
Yeah.
Do you think it should primary CTO practice should be done in a center without CABG facilities, in a center without on-site cardiac surgery?
That's a bit of a controversial question. So in general, again, the textbook answer is yes, you always need surgical backup. And I think you're going to find a split if you ask people. I would have said absolutely yes, perhaps 4 or 5 years ago. Now, having proctored extensively in the APAC region, I've gone to multiple centers where we don't have surgical backup. And frankly, it depends on the team, depends on the operators, because most complications, I mean, in fact, pretty much all complications that we create are managed in the lab. You know, and I don't remember, I mean, touch wood, like the last time I had a surgeon bail me out from a Cathlab complication. So, I mean, the practical answer is no, but you will find a lot of divergence in terms of the answer to this question. The textbook answer is yes.
I have 2 questions.
But you know, Dr. Arif, because whenever I have also complications there, and 1 or 2 patients died of preparation. But you know that at that time, even you don't have that much time. You can't get that much time to just go to the surgeons. So that's not actually, it's not happening. You have to have that all the facilities to because you have all the modalities now. You can seal a perforation. You have if you have those things, then it's okay. You don't need the surgeons.
Thank you, sir.
Dr. Arun, do you hear me?
Yep.
You have enough time to 10 to 15 minutes with us.
Sure.
Sure. I have two questions for Dr. Arun and Dr. Saidur. What is your workhouse wire and to Cathlab for integrate PCI and replicate PCI? Which workhouse wire?
So I'm sorry, could you repeat the question? I'm not sure I understood.
What is your workhouse wire for integrate or replicate PCI in Cathlab? You're usually used to front of you this wire. Why?
So I mean, you know, when I use the term workhorse wire for regular PCI, so I mean, it's one of the Asahi family wires, but I mean, it really depends on the purpose that the wire has to serve. So I think, again, as Dr. Saidur also said earlier, so I mean, if I'm looking for penetration, let's say it's a blunt cap that I got to get across, I typically pick a Conquest Pro 12 or something. If I'm looking for a lot of torqueability, I pick something in the Gaia family, maybe a 2 or a 3. If I'm looking for fine channel tracking, or I have a tapered tip, not much calcium, I'm just looking for fine channel tracking and I want to just penetrate with very little force, it's an XTR or an XTA. So I don't have a favorite. It depends on what is the job I want the wire to do.
Yes, nice. Dr. Professor Saidur Rahman,
just what I can tell, because you know the wires are evolving, because I went to Japan, especially in the Asahi company there, and Dr. Anthony Colombo was there, and the Colombo was telling that in his concluding remarks in that program, in that sister, that was a cultural program also along with it, and Dr. Colombo is, you know, that he's a very funny person and a very sweet person, and he was telling that, yeah, you do. You just go on making more and more wares, because and keep the price high. That was his funniest part. But the thing is that before that Gaia series in Asahi, so we have the wares of the older wares like Miracle, Confienza, intermediate support ware, and the support wares like the hydrophilic wares. We had the Boston PT2 and blah blah, these sort of things. But nowadays, the more and more when you will do CTOs, it's better, which I have shown in my lecture also. In your Cathlab, at least you have some low penetration force ware, that is filter XT, XTA, XTR, and 1, 2, 3. Then second is you should have a Xion black, Xion blue wire series, and third one is the Gaia series. These three are pretty much essential for the beginners and for the intermediate operators. And if you go more and more like Arun, then you will have that because that high frequency, the high penetration for wires like Miracle 12 or Confienza, these are the things, you know, has potential for perforation. So these will be in the backbench. So at least this low and mid frequency wires, penetration force wires, should be in your Cathlab.
Thank you, Dr. Professor Saidur. Dr. Arun, do you hear me?
Yeah, I do. Go ahead, please.
Yeah. During wire oscillation, from the beginners, how are you feeling the tactile feelings of the wires and how to oscillate the wires? As Professor Saidur says, but with experience, how any tips or tricks for the juniors, how to oscillate the wires? Because it is the more uncomfortable for the juniors to oscillate the wire. It is the most important part of the successful CTO. Wire oscillation and feeling the tactile feeling of the wires. You will please share your experience.
No, this is again, I think an important question, but I want to emphasize this. A tactile feel is something that is very, very hard to teach. Now, you know, the whole wiring thing, right? I mean, you got this whole, again, an entire, I think it takes some teaching. How do I say this? You have multiple ways of manipulating the wire. You could drill it. You could just stick it, penetrate it. You could have a sliding motion, etc. Different wires, again, act differently. It is important to realize that the tactile feel that you get depends on, you know, is it a hydrophobic, hydrophilic wire? Is it polymer jacketed or is it not, etc. So while much has been said about tactile feel, I think unfortunately this is the one time where I would say it is really hard and there's no substitute for experience. And again, one other factor is that I tend not to use torquers much, but unless I have to. But there are some people that use torquers. So, I mean, I would say do what you do when you got trained. There are pros and cons again to both. I'm not saying one way is superior or another. If I want to spin really fast, I can get better tactile feel with my fingers. So a lot depends on what you intend doing. I want to add one more thing about the in terms of the inventory of the wires that you have. I would also say have kind of an intermediate polymer jacketed wires, because these tend to stay in the vessel architecture. And I'm talking about wires similar to Pilot 200, like,
Pilot 200, yeah.
Yeah, even if you do,
Mhm.
the worst is you might go subintimal. I'm not saying you can't exit the architecture, but it's unlikely, it's much probably less likely to exit the vessel architecture than compared to a Conquest Pro 12 or even a Gaia 3rd for that matter.
Mhm.
Thank you.
Mohsin, that's Dr. Arun was telling that tactile part, the tactile response, because that is the most important, the mainstay for CTO navigation.
Yes.
The most important thing, and truly, nobody can teach anybody that how you can feel that one. But the most important thing is, which I usually say my fellows, I usually push them to not to use the torque. Those who are using, I'm not against them. It's not at all, not at all. But the thing is that from the very beginning, if you don't use the torque and you start using using your finger, then you can feel really, really, the wire can sing with you. I think easily, because I never use torque for any case, never ever. So never, I have been used to. I don't feel have any sort of comfort with torque. I don't feel. It seems to me like an alien. But those who are with torque with very much comfortable, for them it's okay. But those
I'm
who are
comfortable
starting,
with torque, Saidur.
those who are starting with CTO and those who are newcomers, I usually tell them to feel the tactile response, especially for CTO. Then it's better to off the torque and go with your own finger feelings. That's Jamil
Can I
bhai, I'm
add
telling.
something?
Not for other PCIs, not for other PCIs. You can use torque.
Professor Jamil,
Can I add something?
we are passing 2 hours time. Jamil, Abdul
Yeah,
Jamil.
I do use torque. I feel very comfortable, but I feel the tactile with my left hand. With the 2 fingers, I keep gentle push and goes on torque with the right thumb and index. So that gives me a tactile feeling on my left hand fingers, index and the thumb of the left hand. And I proceed with the torque and look at the monitor, whether it is stacking up, whether the tip is moving or not, and whether it is going puckered there at the tip. These are the things should be cautious, otherwise one might perforate. So what Dr. Arun,
Jamil bhai, you are mentally tactile because you are a good painter, you are a good singer, so you are mentally tactile. So you don't need anything.
Thank you. Last 2 comments, Professor Walil Islam. Dr. Walil Islam, we are passing 2 hours time. Walil Islam, consultant of Everfield Hospital.
Thank you very much. I was actually late in joining the important meeting, and I missed most of the lectures. So
you can hear from the YouTube channel also at late time.
Yeah, definitely I do. I do, and I totally agree with Dr. Said and Dr. Jamil what they're saying about this tactile feelings by whether without torque or with torque, because it depends on the individual perception and practices. So Dr. Said is confident without torque, and Dr. Jamil, and as we often do, feel with the left hand and while torquing with the right hand. So for fellows, usually it's a matter of experiences. So fellows should be learned in methodically, and not by the expert what they are doing, what their boss is doing. So they should be at the beginner. They should be doing methodically, and then once they expertise, they can do whatever they like. Thank you.
Last comment, Dr. Habib Rahman. Dr. Habib Rahman, last comments from you, Dr. Habib Rahman.
Yeah, thank you very much, Dr. Arun and Professor Saidur. I enjoyed both the lectures. particularly Dr. Arun. I am very much fond of his deliberation. I always hear his lectures while he delivers in any conferences, usual. And regarding the lecture of Dr. Saidur, the integrate wire escalation, while we do for the fellows, we should limit our injection, integrate injection. So we should always give retrograde injection to follow the wire. Otherwise, it may extend the dissection. It may create some problems. And also, knuckling the wire, you have to limit your extension of the knuckle. So it may obliterate the collateral vessels as well as other branches. So for the fellows, these are the important points, I think. So I enjoyed both the lectures and I learned a lot.
Thank you. Dr. Arun, my part last question for you. During the dissection re-entry, any tips for the fellows? Dissection and re-entry, just for the fellows.
You're talking about a device-based re-entry?
No, not device-based, but is a simpler way, because there is a device in Bangladesh. So how a fellows doing the dissection re-entry safely?
Okay, so I mean, the first I would say is the indication, which is, let us say this is a lesion that cannot be wired antegrade, so you've kind of made the decision to go dissection re-entry. Number two is, whether you use recross, whether you're using Crusade or Sasuke and using some kind of a dual lumen re-entry, or you're using a Stingray, whatever you use, the fundamental concept in re-entry is that you're going from the adventitia or the subintimal plane, basically you're going extra plaque to intraplaque. So you need a wire with a significant amount of penetrative force. So I'm not sure, based on what the discussions that we just had, I personally think you should get comfortable with Conquest and, or Confianza Pro 12 and Gaia thirds if you're going to start CTOs, because otherwise your success rate is going to be dismally low. But this is the kind of wire that you need if you do want to do re-entry. And the same principles hold when you're doing reverse card and you're still trying to connect across tissue planes. I mean, Dr. Sumitsuji has done, the famous paper where you have antegrade wire through it's intraplaque, retrograde, subintimal, and various combinations. Anytime you want to traverse planes, you need a penetrative wire. So that's either a Hornet 14, Confianza Pro 12. You could get away with the Gaia, Gaia third. And of course, you have the Gaia next ones coming. You have the Judo 6 wires that are coming. You have the Teleflex wires that are coming. But at least right now, I would say Hornet 14, Confianza Pro 12. Those would be your wires of choice entry.
Thank you, Dr. Arun. Thank you again. We are waiting.
Question to Dr. Arun.
Yeah, Dr. Hamid.
What is the difference between Gaia and Gaia Next? Where?
So there is another extra coil. The penetrative force is a little bit better. I mean, we don't have it yet. And one of the problems in the Gaia wires right now is because of the lack of having an extra. So there is basically, you've seen the construction of the wire, right? Gaia itself with the whole Act1 core. Now there's an extra coil that runs around the entire one. So number one, Gaia Next 1, 2, 3 are a little bit more penetrative. So as opposed to 1.7 to whatever in the 4.5 range or whatever, now it's 2, 4, 6 in the Gaia Next series. And number two is that in extreme calcification, I'm sure some of you guys have, at least when you've taken it across extreme calcium, the wire can actually come off. That won't happen in the Gaia Next series. I would say that is probably the biggest advantage.
Thank you, Dr. Arun. I will hope see you again on 11th March. You are the retrograde master, successful CTO retrograde in Asia part. So we are waiting for retrograde technique in 11th March. Thank you, Professor Saidur Rahman. It's excellent lecture. Thank you, Beximco Pharmaceuticals, our scientific partner, and About Vascular. They sponsor this program. I am requesting Professor Abdul Chowdhury, sir, please you concluding remarks and conclude the session.
Thank you very much for the invite, guys. Truly an honor.
both the speakers for the beautiful presentation. The discussion we have later on also points out the finer details. But before, for the youngsters, I would also ask, whenever you are planning for a CTO, start thinking from the guide catheter. If you don't have the support of the guide, not anywhere can actually help. Then think about the where you are trying to do. For that, you need dual injection and if possible, a CT angio that will give you the impression of the length and the probable presence of calcification and other things. As Saidur has said, and also Arun has described, the histology of the plaque also determines your chance of success and can also help you planning for the wire you are going to take. Then think about the other devices, the microcatheter or the crusade, and what way of entry you are going to do. And that means you have to plan. That means you should not hurry. That means you have to have the support of your team. You have to have support of the hospital authority, whether they are going to allow you to have enough time, spending enough time for one case only. All those things are very important if you want to be dedicated CTO master, as Saidur has become. He was saying for last 10 years or 15 years he's doing that, as Arun has become a legend on his own in Asia. And that's the important thing. We have to dedicate ourselves if we want to be a CTO master. And the legends like our presenters today, they can always help you. Thank you, everybody. Thank you, the audience. Thanks, the presenters, and also Beximco and Abdul.
Thank you, sir.
Thank you.
Thanks
Thank
a
you,
lot.
Arun.
Thank you, guys. Stay safe.
Thank you very
Bye-bye.
much. Thank
you,
you, Arun.
everybody.
Bye-bye.
Thank you,
Nice to
sir.
see you again.
Good night.
See you soon.
Assalamu alaikum.
Assalam.
Good night.
Bye, guys. Good night.